Good evening, guys. Welcome to this session. Today, Dr. Ahmed Elazab will be presenting a very interesting topic and a very important one. He will be talking with us about tracheostomy. So, Dr. Ahmed, the mic is yours.
Okay, thank you, Dr. Mohammed. I'm now sharing my screen. Can you see my screen?
Not yet. Yes.
You can see it?
Yes.
Okay. Okay. Good evening, everybody. I'm Dr. Ahmed Elazab, ENT specialty doctor at Prince Alexandra Hospital in Harlow, north of London. Okay, so first of all, so what is tracheostomy? Just a quick definition about tracheostomy. Tracheostomy is some surgical procedure that involves making an incision in the neck, creating a new opening in the trachea. This opening is called the tracheostomy stoma, and a tracheostomy tube then inserted through it to help the patient to breathe. We are doing tracheostomy for several reasons, such as bypassing an obstruction in the upper airway or assisting patients with long-term mechanical ventilations, improving access of to the airway and extra and so on. This is the question why we are performing tracheostomy. The most important thing is to bypass an airway obstruction, actually be above the level of the cricoid cartilage. So anything above this, above the cricoid cartilage here, just below the larynx, anything above this level, making obstruction, we can bypass this by a tracheostomy procedure. The other reason or indication to do tracheostomy is in patients with long-term mechanical ventilations. Those patients are intubated for a long period of time, and to avoid the sequelae of prolonged intubations, we are performing tracheostomy. These patients, like patients with chronic respiratory failure or neuromuscular disorders, they will get benefit from such a procedure. The other indication is including airway protection, such as in patients who are at risk for respiration, as in patients with severe neurological deficits or swallowing disorders. Another also indication is airway clearance. Patients with certain medical conditions like cystic fibrosis, bronchiectasis, they will also get benefit from tracheostomy. We may also do tracheostomy as rarely, but it is one of the indications to access procedures like taking a bronchoscopy or taking lung biopsy. This can be done through tracheostomy tube. So also one of the common indications to perform tracheostomy is a trauma. If the patient has a facial and head trauma, and to secure the airway and give a chance for the surgeons and the maxillofacial surgeons to reconstruct the head bones and the maxilla and things. So tracheostomy is far away from the head, so you secure the airway and give them the chance to do whatever they want in the head's bones. I guess is what is the changes in the respiratory physiology after tracheostomy? Actually, we alter the normal physiology of the upper respiratory airway. This after putting the tracheostomy will somewhat increase the airway resistance. This may be something that's strange, but it is actually may happen the tracheostomy tube may be narrower than the tracheal rings itself. This maybe accumulated secretions around the tracheostomy tube. This will make the airway narrower and increase airway resistance. There is also alterations in the mechanics of the lung, like being less elastic in terms of pressures around inside and outside the lung. Changes in the ventilation perfusion ratio maybe also a result happen with the tracheostomy. Alteration in cough strength and secretions clearance. Patient has to make a good cough. You have to have creating pressure against inside the lungs to have a good cough. So when we normally cough, we close the airway for a few seconds to create a positive pressure, and when this pressure becomes bigger than the pressure, the atmospheric pressure, the patient is able to cough and clear the secretions. This is impossible with the tracheostomy. The patient cannot create a positive pressure in his own. Also, the patient with tracheostomy cannot speak. He cannot speak because there is no air flow to move the vocal cords for the patient to speak. In terms of types of tracheostomy, we have types of tracheostomy, mainly the surgical or open tracheostomy and the percutaneous tracheostomy. There are other types like mini tracheostomy, this less invasive way to do tracheostomy, and the emergent tracheostomy. It's also something that a quick procedure. I will discuss steps, surgical steps rapidly, and when we do tracheostomy. So the surgical tracheostomy can be done under either local or general anesthetic. So it depends upon if it is an emergency situation, we can do it under local anesthetic. Or if it is an elective procedure, such as in patients with long-term mechanical ventilations and prolonged intubated patients, so we can do it under general anesthetic. When we do either local or surgical or general anesthetic tracheostomy, we have to position the patient in a position that brings up the trachea more superficial. So the neck should be fully extended as much as we can. We put the neck, put the shoulder support to fully extend the neck. So then we will mark that site where we are going to do our incision. There is multiple types of incision, but I'm personally doing the transverse one, which is more cosmetic. We mark the incision midway between the cricoid cartilage and the suprasternal notch. So we mark here just below the thyroid cartilage is the cricoid cartilage. We just put a mark here and go down to the suprasternal notch and do another mark. Midway between them, we make our incision. This should opposite to the second, third tracheal rings, where we will open the tracheal window. After doing the incision, we do this section of the skin, subcutaneous tissue, and platysma and fascia. Dissect the strap muscles. Try to every now and then we should make sure that we are in the correct way, because if you miss your way, and you may go beyond the trachea and go to the esophagus and make a horrible problem complication, opening the esophagus and making intestinitis, which is one of the complications. So once you make these sections, you will finally the final layer is the thyroid isthmus, which one of the challenges facing us when doing tracheostomy, to either cut the thyroid isthmus, which is results in bleeding, or retract it up. After that, we will find the trachea, identify the trachea. Personally, even though I'm sure that this is trachea rings, I'm still need to make sure that I am in the correct pathway and this is something, not something else. So we insert a needle in the trachea and try to aspirate air, so to make sure that I am in the correct pathway. There is a pretracheal fascia that needs to be also dissected. I'm doing it with diathermy. If this pretracheal fascia not left open, this may result in complications later, like emphysema or mediastinitis as well. Once we identify trachea, we open a little window, just remove the part of the second to third tracheal rings, making it like a window inside the trachea, and then insert our tracheostomy tube and make sure that the tube is in the correct placement. At this stage, we always, before inserting the tracheostomy tube inside, we always ask our anesthetics not to remove the endotracheal tube completely, because the tube may fail to go inside the trachea. So we make sure that the trachea tube is in place when we connect it to the anesthetic machine and get the correct readings. After that, we secure the tracheostomy tube to the skin with sutures, and this the procedure should be ended. And we actually move to the next step, which is the post-operative care after the tracheostomy. There's multiple types of tracheostomy tubes, including curved tracheostomy tubes, uncurved tracheostomy tubes, fenestrated tubes. It depends upon the situation. In patients with prolonged intubation, actually these patients may be connected to ventilation, mechanical ventilation, so they should have a curved ones to secure the airway. Also, patients who are exposed to maybe aspiration, they should have curved ones. Patients with who are will in the future begin dependent on the tracheostomy tube, or patient who needs to needs to be able to talk. In these patients, we may use the unfenestrated, the uncovered ones, or with a fenestration or without. It depends. Yeah, and of the tracheostomy tubes that I'm not sure why it is not available in hospitals here. That one we called adjustable flanks tracheostomy tubes. The one down here. This one you can adjust the length of the tracheostomy. So if the patients have some sort of a lower down obstruction below the level of the cricoid, it can goes more further down, or patient with a very thick neck. This one will also be helpful to get inside the tracheal lumen, probably. Complications may face as after tracheostomy or during the tracheostomy includes infection, bleeding, tube displacement, which is something that may happen in the ICU. Commonly, the patient, while repositioning the patient or so, the tracheostomy tube can be displaced. And this is a challenge because, yeah, immediately after tracheostomy in the first few days, there is still not yet stoma is not yet developed, and all the tissues will collapse, and the doctors in the ITU will feel difficulty in identifying the tracheal window to reinsert the tube. Personally, I'm always make a window instead of making a window. I make like a flap of the trachea, and stick a inferior based flap in the trachea and attach this with Velcro to the skin. So even the tracheostomy tube displaced, we still have a way to identify the tracheal window and reinsert the tracheostomy tube easily. We also making sure in the operation that we stitch the tracheostomy tube to the skin and make it difficult to be displaced. Surgical emphysema is also one of the complications that may happen, especially if the fascia, peritracheal fascia, and are not cauterized well, to make sure they are not, especially with patients with high pressure ventilation. This may create pressure of air that escape by what may and escape inside the subcutaneous tissue and the facial spaces in the neck. This also we also need not to tightly close the surgical incision we made at the first step to guard against development of such condition. We may at sometimes injure the apical the lung apex, and this may result in pneumothorax. With patients with long-term tracheostomy, they may develop tracheal stenosis. Also, patients may develop dysphagia as the process, maybe due to hyperinflated tracheostomy cuff. It may press on the esophagus as well, or with the development of fibrosis and things. One of the most common things is to have a stoma granulation tissue. This was patients with also with a long-term tracheostomy with during in the stoma of the tracheostomy tube, there will development of granulation tissue that results in bleeding and infections and so. One of the most dangerous complications that I never saw, and luckily I never saw it, is bleeding in long-term patients with tracheostomy tube. They may have developed a tracheo-innominant artery fistula. Patients who are neglected, not changing the tracheostomy tube regularly, with the pressure created on the from the tracheostomy tube on the trachea. This may create a tracheo-innominant artery fistula. When the tracheostomy tube is going to be changed, once the tracheostomy tube is removed, a horrible bleeding will happen, and this is very, very life-threatening condition. So this is why we are always tend to do tracheostomy exchange during the daytime in the emergency situations, and taking every precautions to prepare yourself for such horrible complication. Post-operative care includes of the patient after tracheostomy, includes doing regular suctioning because the patient is unable to cough, so we have to remove the excessive secretions by regular suctioning. Tube care, regular exchange of the tube. Patients, always the patients are ITU patients. They need to be nutritionally supported, need mobilization, and things like this. Yes, that's. I hope I covered some of the most important points in tracheostomy, and I'm happy to receive any questions. Yeah, Dr. Mohsen.
Thank you, Dr. Ahmed, for the presentation about tracheostomy. I have few comments which are related to intensive care and looking after patients with tracheostomy. The first comment is on the indication. I know initially they used to say like endotracheal tube shouldn't stay in a patient for 14 days and then you have to switch it to a more long-term plan with a tracheostomy, but the practice has changed nowadays and we usually don't follow it strictly. It's mainly the outcome and the target for the patient himself. If the patient has a favorable outcome and we expect like he will come out of this event, we can extend the endotracheal tube more longer than these 2 weeks. But if we sure that the patient might need like a month or few months of rehabilitation, then we will do the tracheostomy. But if the event is unsurvivable and we are sure that like if the patient has a stroke, initially ventilated for some reason, and then by the end of these 2 weeks we know for sure that this stroke is a devastating one, we usually don't go to tracheostomy. It will be more switching to palliative care rather than tracheostomy and prolonged ventilation and put the patient at risk for all these complications that you have mentioned already. The other comment is about the adjustable flange, and it is available in the UK. We don't have it in our trust. Probably you don't have it in your trust as well, but we did receive patients from outside here in the Northwest, and they came to us with an adjustable flange tracheostomy, so it is available. You might see a patient.
I don't know why is this. Maybe the family can buy it, but I'm in an emergency situation.
No, it's I think it's
very abused,
it's
and
just a supply source for the trust. The company who is supplying, like us, the company who is supplying to us doesn't have an adjustable flange tracheostomy. So
yeah, you know, I'm new to the UK, and this was one of the most strange things I find, because this may be life-saving for patients. Patient was operated 2 days ago, and now patient was very obese and was COVID positive, and actually the tracheostomy tube is very short, and it was dislodged very easily, and the end by reintubated him again, and because there is no adjustable flanks was available to remove the short one and put one of these. This was one of the strangest things that I found here. Okay.
It is, yeah, but I think you might, like here we do have like a network of few trusts. You can ask if somebody can, some of these other hospitals can provide you with the adjustable flange.
Yes.
And I think they have requested one for one of the patients, as you said, very obese, ordinary size tracheostomy tube wouldn't fit in him, and
yes, for sure.
they had to do it. The final comment is about the bleeding, and I've just remembered one of the patients when you described the arterial bleed after a long-term tracheostomy. He was a young patient with ALS. He was tracheostomized for about 6 months in Saudi Arabia. Definitely the outcome was, everybody knows that he will aspirate at some point and die because his disease is not curative. But he didn't die because of that. He died because of massive bleeding from his tracheostomy, and it was an arterial bleed. Nobody managed to control it. He died within minutes.
Yeah.
So
despite it is a very easy procedure to change tracheostomy, but it is very risky, and this is
it is.
And yeah, so the team say it's very easy, please come and change it at the end of the day. This is risky because you may face a horrible bleeding and nobody to assist.
It was a very traumatic experience, and nobody was expecting it to happen. It just started all of a sudden, massive bleeding from the tracheostomy, and you can't control it by any means, and the patient died. This is just a few comments I wanted to share with you. Thank you for the presentation.
Yeah. Thank you very much. Thank you.
So thank you, Dr. Ahmed. I wanted to make the same comment that Dr. Mohsen already made. So of course he is our senior and he knows more. So anyone else has any comments or questions at all?
Yes, please. I got a question. Two questions, please. First one is if the patient is already intubated and ventilated. So what's the technique? What do you do right then? Do you take the AT tube first, then you put the tracheostomy tube, or do you put them both together at the same time? And the other question is, how long can you leave the tracheostomy tube in place before you change it? Thank you.
Okay. The first question, while we are doing tracheostomy tube, tracheostomy in patient who is long intubated, already intubated, so he can be easily generally anesthetic, receiving general anesthesia. Okay, and we keep the endotracheal tube for the whole length of the procedure until we open a window in the trachea. Okay, so once we open the window, we will see the cuff of the endotracheal tube in front of us. And we will ask the anesthetic team to very slowly drag the endotracheal tube, very slowly drag it out, take it out very slowly while it is going up. Once we see the lower edge of the endotracheal tube, the anesthetic team should stop at this point, and we introduce our tracheostomy tube. And the endotracheal tube should be in the same place like this until remove the connection from the endotracheal tube, the ventilator connection to the tracheostomy tube, and make sure that the carbanogram and everything is okay before saying yes, okay, so we can remove the endotracheal tube. One of the wrong, most common mistakes happening that if there is no connection between the surgeon and the anesthetic team, they will, once you said that I opened a tracheal window and I am inserting the tracheostomy, they remove the endotracheal tube directly. If this should be discussed before starting the procedure, to make a plan with the anesthetic team to let them know that we are not removing the endotracheal tube until we are sure that the tracheostomy tube is the correct place. The second question, it depends upon the type of the tracheostomy tube. So previously in the past there was a silver tracheostomy tube. They are lasting for a long time, and they can be removed and cleaned and inserted again. Nowadays we are using plastic ones, Shelley's, and this one I think lasts for maximum of 6 months. Every 6 months should be exchanged, and preferably 3 months will be better to remove it every 3 months. And definitely, whatever the length that the tracheostomy tube was in, even if 1 day, but if there is difficulty in breathing, so suspect that some sort of mucus plugs is obstructing the tracheostomy tube lumen, and you should consider remove it and exchange it with a new one before searching for any other causes of patients' difficulty in breathing. But typically 3 months is fine, or at most 6 months.
Okay, thank you very much, Dr. Ahmed. Thank you.
So any other comments or questions to be added?
I have a question, if you allow.
Okay, go ahead.
Yeah. When not to do a tracheostomy? Any idea?
Well, I think if we are in a terminal situation, it's not very wise to perform a tracheostomy then.
Yeah, actually, I ran out of time. I have to add this to the slides, but if I know to add. But actually, there is a situation we should not do tracheostomy in patients, like patients with low hemoglobin levels. So this is risky for the patient to do tracheostomy. it can be postponed or maybe cancelled in patient with end of life, or there is no hope for him to improve, and this will be an unnecessary procedure. Okay, patient with a lower obstruction below the level of the cricoid, below the upper trachea, so lower down in the carina or just above the carina. This will not benefit from tracheostomy. Patient with coagulation problems, bleeding problems, it will be risky to do tracheostomy in such patients. Anybody has any idea about when not to do tracheostomy?
I thought you mentioned already the technical difficulties, isn't it? Because
Yes.
some patient will have like deformities in the C-spine and their neck will be just touching their chest. There is no access at all that you can do a tracheostomy for.
Yeah.
I've seen one
Yeah,
patient, he's young chap, very unlucky, and he has spine deformity since birth with restrictive lung disease, and there's no way to even put an ET tube because of the deformity, and definitely tracheostomy wouldn't be applicable at all.
Yes. I have a question for you as well, as an ITU, the percutaneous tracheostomy. I'm not experienced with it, but yeah, I didn't do it too much. I didn't do it at all. Is it technically difficult for you to do this in the ITU settings?
No, it's not difficult. We use the Seldinger technique, like the central lines,
Yes.
and it needs 2 operators, not one. So one will be holding the airway with bronchoscopy, make the view for you, and then the main operator will be doing the tracheostomy itself. It's but the procedure is pretty the same, like inserting a central line.
Yeah,
so
and I found it easy.
easy.
I know about it, but it is easy. Yeah,
It's easy, but it's somehow, yeah, you still have the bronchoscopy with you, but the surgical bit of it is almost blind. Like you go with a needle, you put the guide wire, you start dilating, but it's not as controlled as the surgical one. So we do an ultrasound of the neck beforehand to be sure that we don't have any major blood vessels coming in the insertion site. If there is any blood vessel that we're worried about, we'll switch to the surgical trachea because it's, as I said, it's more controlled.
Yeah, it is. It is one of the common indications for tracheostomy. Surgical tracheostomy is having a big blood vessel, like in the anterior part of the neck.
Yeah, at the front of the neck. Yeah.
Yeah.
Do you have any more questions?
No, I'm fine.
So anyone else has any questions? Okay, so it seems that we don't have any more questions. So finally, before we end this session, I remind you all to complete the session, the feedback of the session. And fortunately, this time you will earn 1 point of CPD as well. So this will be the gift of attending the session. So thank you all, and thank you, Dr. Azab. And
thank you very much.
Let's meet again in another session.
Thank you very much. Thank you.
Thank you.
Thank you very much.
Thank you. Bye-bye.
Bye.
Bye.